1. And 10-year-old boy became unsteady and unable to walk all of a sudden this afternoon. Despite of being scared, he is very cooperative and well-spoken. On examination, he has mild bilateral lateral gaze, nystagmus, past pointing on finger-nose-finger, test, and normal reflexes. He has a gnaw, mal strength, but he cannot balance while standing, and he has a lurching gait. He had chickenpox 14 days ago, but he is otherwise healthy. Develop. Mental milestones are normal. What is your most likely diagnosis? A. Acute post-infectious cerebralitis. B. Friedreich ataxia, FRDA. C. Medulloblastoma. D. Miller-Fisher syndrome. E. Multiple sclerosis. Correct answer is A. Acute post-infectious cerebralitis can present as acute onset of cerebella. Symptoms maximal within a few hours, following any viral infection by 10-14 days. Usually the sensorium should remain clear. MRI of the brain may show increased T2 intensities in the cerebellum. Improvement should begin within a few days of onset, and gait should normalize within 5 months. 2. An 18-year-old girl is evaluated for fatigue. Her roommate accompanies her today and contributes to the history by stating that the patient has lost weight in the last year to impress a guy. However, even after they broke up, she felt obsessed with her appearance, often feeling overweight despite being told the contrary. On examination, her body mass index is 14. Normal is 18.5-24.9. She has thin hair and has goosebumps on her skin. There is diminished muscle bulk throughout, with prominence of her bony structures. Which of the following is true regarding the patient's diagnosis? A. Body weight is usually normal in this condition. B. Males are most prominently affected in this condition. C. Amenorrhea is often associated with this condition. D. After eating, most patients with this condition purge through self-induced vomiting, laxatives, or diuretics. E. There are no medications that have been shown to help treat this condition. Correct answer is C. The patient in this question most likely has anorexia nervosa. This is a disorder that affects 1% of adolescent girls, only 5%, 10% of patients with anorexia nervosa are men. Most have weight loss, associated with a fear of being overweight that often leads to starvation and excessive exercise. Patients refuse to maintain body weight at or above the normal weight for age, and also have an altered perception of their body weight. In those who have begun their menstrual cycles, there is often amenorrhea, defined by the absence of 3 consecutive menstrual cycles. Patients with anorexia nervosa can also binge eat and purge so long as they are still underweight. Alternatively, patients with bulimia nervosa must have recurrent episodes of binge eating, eating more than what others would eat in a discrete period, and purging through vomiting, laxatives, diuretics, enemas, or exercise, but have a normal body weight and generally poor control over eating habits. Binge eating and purging must occur at least 2 times per week for at least 3 months for bulimia nervosa. Treatment includes nutritional counseling, psychotherapy, and selective serotonin reuptake inhibitors. 3. A 17-year-old girl arrived to class immediately after cross-country running practice. While sitting at her desk, she felt sweaty, warm all over, and nauseated. She then slumped forward with fast, jerk-like movements of her arms and legs. Her teacher rushed over to lower her to the floor, and she quickly began to rouse. She initially appeared confused, but was able to answer questions appropriately. She had some urinary incontinence during the episode, but no tongue trauma. She returned to her baseline mental status within a few minutes of the episode, but was taken to the emergency room nonetheless. What is most likely the diagnosis? A. Complex partial seizure. B. Convulsive syncope. C. Nonpoleptic spell. D. Absence seizure. E. Generalized seizure. Correct answer is B. The case is consistent with convulsive syncope based on the history of recent vigorous exercise. A. Prodrome of nausea and diaphoresis and loss of consciousness. Additional components of her presentation that suggest a syncopal etiology rather than seizure include the brevity of her loss of consciousness, the brevity of the postictal confusion, and the fast jerk-like movements that were likely myoclonus. Note that there was no mention of repetitive or stereotyped movement before losing consciousness that would suggest automatisms or tonic-clonic activity. There was a loss of bladder control during the episode, but this can occur with any alteration in consciousness. There is nothing in the question stem that would indicate a non-epileptic spell. The diagnostic workup for syncope would generally include orthostatic vital signs, an electrocardiogram, Holter monitor, and/or transthoracic echocardiogram if there is a high suspicion of a cardiac etiology. If events are recurrent, an electroencephalogram may also be considered in case of an atypical seizure presentation. Treatment for the case presented would likely include volume resuscitation with no other definitive therapy, indicated unless there are abnormalities on evaluation. If the patient suffers recurrent syncope, both conservative measures, that is compression stockings, abdominal binders, liberalization of salt intake, moving legs before standing, and pharmacological measures, that is fludrocortisone, midodrine, droxidopa, pyridostigmine, may be considered. 4. A 12-year-old boy presents to the office for evaluation of weakness. With exercise, he gets cramps and fatigue in his legs to the extent that he is unable to keep up with his peers during gym class. Cramps usually occur within minutes of starting exercise, and he seems to get a second wind if he is able to rest for a few minutes. After the cramps begin, he denies dark urine. His neurological examination is normal. Serum creatine kinase CK level is elevated at 650 IUL. Normal is usually 5200 IUL. An exercise forearm test is performed and shows a normal rise in ammonia, but no rise in the lactate. The patient's most likely diagnosis is caused by which of the following? A. Alpha-glucosidase deficiency. B. Myophosphorylase deficiency. C. PMP22 duplication. D. Absence of muscular dystrophin. E. Debranching enzyme deficiency. Correct answer is B. McArdle disease, also known as myophosphorylase deficiency or type V glycogenosis, is an autosomal recessive disorder resulting in a deficiency of myophosphorylase. This is the most common disorder of carbohydrate metabolism. Patients typically present in childhood with exercise intolerance, cramps, and pain induced by brief, intense activity. CK may be elevated. Often a phenomenon known as second wind is seen with McArdle disease, which involves a return of strength and reduction in pain after a short rest due to mobilization of blood glucose as a muscle energy source rather than relying on breakdown of glycogen. An exercise forearm test can identify a disorder of the glycogen metabolism by measuring levels of ammonia and lactate. In this test, baseline ammonia and lactate levels are drawn, followed by intense exercise of the hand with levels of ammonia and lactate drawn at. Serial intervals. Glycogen metabolism disorders show a normal elevation of ammonia, but a lack of rise in lactate. The diagnosis is confirmed with a muscle biopsy that shows a lack of uptake to a myophosphorylase stain. Alpha-glucosidase deficiency is also known as Pompe disease. The most common form of this condition presents in childhood with hypertonia, cardiomegaly, and hepatomegaly. The juvenile form presents with progressive proximal muscle weakness, lumbar lordosis, and a waddling gait, which can appear similar to Duchenne muscular dystrophy, DMD. An adult form presents in the 40s with proximal muscle weakness similar to polymyositis. Pompe disease is diagnosed with an assay for alpha-glucosidase activity or muscle biopsy. PMP22 duplication is the genetic defect seen in Charcot-Marie tooth disease type 1A, which is an autosomal dominant hereditary demyelinating neuropathy. Absence of dystrophin on muscle biopsy makes a diagnosis of DMD, which presents with progressive weakness, pseudohypertrophy of the gastrocnemy, and a Gowers sign typically in young males. There is no second wind phenomenon in DMD. Debranching enzyme deficiency is a rare glycogenosis that presents in the 3rd to 4th decade and causes severe weakness and atrophy of muscles, often mimicking amyotrophic lateral sclerosis. Liver failure can also occur, but there is no second wind phenomenon. 5. A 7-year-old boy presents for evaluation of side-to-side head movements and frequent throat clearing in the last 3 months. Each movement is preceded by the urge to move and a sense of relief after. His parents have noted frequent hand-washing and the need to flip the light switch multiple times before going to sleep. All of the following could be used to treat this patient except A. Pymazide, B. Clonidine, C. Tetrabenazine, D. Fluoxetine, E. Methylphenidate. Correct answer is E. Tourette syndrome is marked by both motor and or phonic tics and can be associated with obsessive compulsive disorder, OCD, and or attention deficit / hyperactivity disorder, ADHD. In this question, the patient has motor and vocal tics along with OCD. Behaviors. Tics can be treated with a variety of medications that block or deplete dopamine, including antipsychotics, risperidone, pimozide, haloperidol, flufenazine, or tetrabenazine. Other agents used to treat the comorbidities of Tourette syndrome include centrally acting alpha-2 antagonists, clonidine, guanfacine, or selective serotonin reuptake inhibitors. Methylphenidate would not be used in this patient because of the lack of ADHD symptoms.